So good morning, everybody. I would like to introduce Christoph Kümmerli. He's a fifth-year resident at our department, and he plans to go to Vienna in January. Yeah. And this morning he wants to give us an update on proctology.
Thank you very much for this kind introduction. And I'm happy to add one more presentation to our collection on YouTube. And we're going to talk about proctology today. It's a broad field and we have many diagnoses, so we'll focus on these three: hemorrhoids, fissure, and fistulas. First, we start with a case. We have a 40-year-old man. We see him in the emergency department. He has itching in the anal region, bleeding, and prolapse during defecation, and he has a history of constipation. So what's the diagnosis?
Hemorrhoid?
Exactly. And when we talk about prolapse during defecation, when the patient also tells you that prolapse is spontaneously reducible after defecation, what grade is it? Do you know that? So we come to that later. So the hemorrhoids is a very common disease. Even the unreported number is even higher because of the easily available over-the-counter drugs. And many people treat them without ever seeing a doctor. When diagnosed, 50% are asymptomatic, and the peak of diagnosis is between 45 to 65 years. And this leads to about 4,000 operations a year in Switzerland. So I'll give you a quick repetition of the anatomy of the anal canal. The canal varies in length and is shorter in women. The most important structure, so when talking about hemorrhoids, is the dentate line, because when you cut below, it is extremely painful for the patient. And also you see here the rectal corpus cavernosum, and this is the arteriovenous cushion responsible for the continence when it's not enlarged. And when it is enlarged, we're talking about hemorrhoidal disease. And you see the first, so we have 4 grades for hemorrhoids. The first degree, the hemorrhoids do not prolapse, and they're simply protrusions into the lumen of the anal canal of the corpus cavernosum. So these hemorrhoids have the potential to bleed, but they don't prolapse during defecation. And they cannot be visualized on examination without the aid of an anoscope. The second degree hemorrhoids prolapse outside of the anal canal during defecation, but reduce spontaneously, as we seen in our patient. And the third degree hemorrhoids prolapse but require manual reduction, whereas the fourth degree hemorrhoids they prolapse and are irreducible. So what is the treatment? First line treatment is always change of lifestyle and also medication. Even in the setting of when you emergently treat hemorrhoids, you start this treatment after the operation. And the meta-analysis showed that the laxatives in the form of fiber had a beneficial effect in the treatment of symptomatic hemorrhoids. The risk of not improving hemorrhoids and having persisting symptoms decreased by 53% in the fiber group, especially less bleeding. And when we look at the phlebotomics, a beneficial effect could be shown for the outcomes, especially for bleeding. You see the odds ratio here. But also for the overall symptom control, we have quite good results compared to placebo or no therapy. These are all kinds of drugs that are available, most of them over the counter, and I just want to highlight the metamucil and taflon that we normally give. So the groups are laxative for the stool regulation, so the goal is a soft stool, of course, and this should lower the pressure in the anal canal. Then the venotoning agents are supposed to reduce the hemorrhoidal tissue because of the higher tone of the veins. And the others are for local symptom control, and steroids as well, because inflammation is also believed to be part in the pathophysiology of hemorrhoids. So now we're going to talk about the surgical treatment, the Milligan, Morgan, the Ferguson, and the ligature, and the Longo are the 4 surgical treatments that we're going to talk about. And those 2 are, in some studies, are grouped as traditional resections. So the Milligan-Morgan is a hemorrhoidectomy, and it includes the resection of skin for drainage, and it starts here. And then also, of course, of the hemorrhoidal tissue. The drainage of the wound is then achieved through the skin defect that is left open, as you can see here. And important is to leave sufficient skin between the resection area to reduce the risk of anal stricture. So this normally results in 2 to 3 hemorrhoidectomies, and this is the final result here. Ferguson, also termed closed hemorrhoidectomy, it is exactly the same, but you close, or you partially close the defect of, but you leave a bit of a draining area, and this results in a smaller wound area. Then the ligature, it combines pressure, so this is the device. It combines pressure and energy to create vessel and tissue fusion, and then a cutting device is integrated, and so you grab the hemorrhoid, and then you dissect above the dentate line here, and finally the specimen looks like this. The last treatment that we're going to talk about today is the Longo, also called the stapled hemorrhoidectomy. This is a bit more complicated. First, you do an anoscopy, and then a circular purse string suture is placed above the base of the hemorrhoids, and after insertion of the staple head here, the stapler head, the knot is tied, and then the stapler is connected, fired, and first, before you fire, you should do in female patients, you should do a vaginal exam to make sure that that you don't damage the vaginal wall. And then, after you fire the staple, it looks like this. So you see the circular anal canal here, and with the stapler, and after the resection, and the advantage is that you don't see a wound, and it does not need any wound care after the operation. The key in this procedure is to properly position the suture. When it's too proximal, you have insufficiently repositioned the hemorrhoids, and in distal shift, when you have a distal shift below the dentate line, we might cause severe postoperative pain. So now we're looking at the data. First, the traditional resections, Milligan-Morgan versus the Ferguson. So we found a meta-analysis with 11 RCTs and many patients, and you see that the pain, wound healing time, and bleeding favors the Ferguson. This seems reasonable because of the smaller wound area, but of course, because you do an additional suture, it takes longer. When we compare the ligature versus the traditional resections, we found a meta-analysis as well, and it shows that the early pain is less when you use a ligature device, and when you look at the operating time, it's shorter when you use the ligature, and also the blood loss is less. That's probably because of the better vessel sealing mechanism of the ligature. And another study that was a randomized trial showed that recurrence was similar in both groups. So we're talking about very good procedures and also very safe procedures. And to sum this up, we have shorter operation time, less pain, less bleeding, and equal recurrence rate in those 2 procedures. When you compare the ligature and the Longo in higher grade hemorrhoids, so grade 3 or higher, we found a meta-analysis, and so the pooled analysis favors the ligature when you look at the recurrence rate, and also the operation time, although only 3 and 2 studies respectively were included. And but we can, I think we recommend that you use Ligasure in higher grade hemorrhoids. And when we compare the Longo and the Milligan-Morgan in any or higher than grade 1 hemorrhoids, we found one RCT comparing, and it clearly shows that patients after Milligan-Morgan have higher or experience more pain than after Longo. The success rate is very high in both procedures. There are also very low complications. They're equally safe, but clearly more pain in the Milligan-Morgan group. So this is the treatment overview, as we partially also use it here. So in grade 1 hemorrhoids, we don't need surgery, and we start resectional procedures from grade 2. We don't do the Hall-Rahr, so I'm not going to talk about this procedure because it has a high recurrence rate. And you can always use, I think, important message is that you can always use the Ligasure resection. And in presence of complicated hemorrhoids, and this includes bleeding, strangulation, necrotic tissue, and thrombosis, you would also prefer Ligasure resection. So to sum it up, procedures in treatment of hemorrhoids are well defined. We have a stage-dependent treatment, and hemorrhoidectomy is standard for grade 2 or higher hemorrhoids. And in general, the procedures are very safe with high success rate, but the pain remains an issue. But we believe this is surgeon-related, especially when you should keep in mind that you cut above the dentate line, as I've shown you in one of the first slides. So we're going to switch to our next topic, and I'd like to introduce you this 44-year-old woman. You see her in the emergency department. She has a bleeding and pain during and shortly after defecation, and she also has a history of constipation. So what is the diagnosis here?
I would think of a fissure.
Exactly, and this is what it looks like. A fissure is a longitudinal tear in the anal canal, and where this leads to exposure of the internal sphincter fibers, and it is the second most common reason for proctological consultation. We have the fissures with a typical location. This is at 6 o'clock, so about 75% are located there, and also in the posterior part. So here is the posterior part of the anus. We have almost 90% are located in the posterior part, and every other location is atypical. We can also distinguish primary fissures. They are caused by defecation habits, so basically a hard stool, and secondary fissures. These include sexually transmitted disease, carcinoma, anal carcinoma, Crohn's disease, but also post-traumatic, for example, after endoscopy. To understand the treatment of fissures, I think it's very important to know something about the pathophysiology, and there are 3 factors important. First, the mechanical stress. So this is normally the stool that is hard, and then we have a second, the hypertonia or spasm of the internal sphincter. It can be primary or secondary reflex to the pain caused by the raw ulceration after triggering mechanical stress, resulting in a vicious circle of repeated anal trauma due to the reflex sphincter spasm. And the third factor is the perfusion. When we look at the number of arterioles from the rectal artery, from the inferior rectal artery, that's the inferior rectal artery, we see a higher number of arterioles in the anterior part. So that probably explains that most fissures are in the posterior part of the anus. We talk about acute fissures when first symptom is present no longer than 6 weeks, and this is what it normally looks like. So it's simply a tear in the mucosa. The treatment aims to reduce spasm of the sphincter, relieving pain, and we use topical or systemic analgesia. You should also address the defecation habits with laxatives, and you do a chemical sphincterotomy, and we're going to talk about sphincterotomy a few slides later. And this leads to a very high, I think even higher success rate in treatment of acute fissures. Talking about chronic fissures first, you see this is a chronic fissures, so defined as symptoms of longer than 6 weeks. And you see here typically a skin tag. You see the edge of the defect is raised, and you also see the visible fibers of the internal sphincters. So chronic fissures have a lower healing rate than acute ones, and without surgery the healing rate is less than 50% and the recurrence rate is higher than 50%. How we treat chronic fissures: we do a fissurectomy, and this should create an environment for healing, to promote healing, and then a sphincterotomy is the next step. You could do a lateral internal sphincterotomy, so that means that you cut the internal sphincter. This is a very effective therapy with a success rate of over 90%, but the problem is that you have a very high incontinence rate. Even after 20 years, patients report new onset of incontinence after such treatment, so we don't do it. We also do a chemical sphincterotomy. So now I want to explain to you how we do the chemical sphincterotomy. We normally use topical treatments. We have 3 agents, nitrates, calcium channel blockers that we know well how they function, for example, in the treatment of arterial hypertension, and we also know how Botox works. So this blocks the sympathetic neural activity, but it has to be injected between the sphincters, so it's invasive. And when we look at the data, the calcium channel blockers and the Botox, we see the similar cure rate after 12 weeks, but the Botox is invasive and it's much more expensive, so we prefer the calcium channel blockers. And when we compare the CCB and the nitrates, we found one meta-analysis, and the healing rates are equal, but the side effects are higher in the nitrate group, especially the headaches. So up to 70% of patients develop headaches after such treatment, and the recurrence rate is only slightly higher in the nitrate group. So fewer adverse events and recurrences with the calcium channel blocker. So in our institution, this is the standard treatment. And to sum it up again, the fissure treatment consists of reducing mechanical stress and also reducing sphincter tone to create an environment for healing. And in chronic fissures, this can only be reached with a surgery. So now, for our third topic, I would like to introduce King Louis XIV of France. So all the history aficionados amongst us are wondering if this shows King Louis in February 85. It does not, because King Louis is sitting, comfortably sitting on a horse, but he would probably not be very comfortable on that day because he had a perianal abscess diagnosed back then. And of course, abscesses can lead to fistulas, and so normally you do a follow-up visit to examine the patient after the abscess is treated. And indeed he had fistula diagnosed in May 85. So this does not show him in May 85. In fact, this painting was made in 1674. In the background, you see the city of Besançon after he conquered this, or his army conquered this city. So he did not have a proctological problem back then, or at least it's not documented. So when we talk about fistulas, fistula is a connection between the anal canal and the atmosphere. And this is the Parkes classification, the original publication, and it classifies the fistulas according to the relation to the internal and external anal sphincter. In addition, in fistulas in Crohn's disease, they are further evaluated because of their complexity with MRI to describe the activity of the disease. So when we treat fistulas, we can simply do a fistulotomy. The healing rate is very high, but the problem is the higher the fistula, the higher the incontinence rate. And the question is, what was the treatment of complex fistulas? And the goal clearly is that the eradication of the fistula tract must be achieved with maximum sphincter preservation. So we go into now other treatments. Apart from the fistulotomy, you can do a fistulectomy with sphincter repair. Here you completely dissect the sphincter until you have direct vision of the dorsal fistula aspect, as you can see here. Then you excise all the granulation and epithelial tissue and the scar around the fistula. And then you immediately start this end-to-end reconstruction layer by layer. So you start with the external, then the internal sphincter, and then the mucosa, but you leave this part open for drainage. The advancement flap is another procedure. You normally start at the outer orifice of the fistula. The defect in the anal sphincter can then be closed using absorbable sutures. For the mucosal flap, the mucosa is lifted from the underlying tissue. The dissection is then performed in the submucosal space to create the flap, which is used to close the inner orifice of the fistula. You can also do a full thickness flap using the whole wall of the rectum until the perirectal space. And important is to remove all the scar formation also from previous surgery. The anal fistula, just quickly, this is when you insert a collagen into the fistula tract from the inside. And the lift procedure, we do this here quite often. The principle here is to interrupt the fistula tract in the intersphincteric space. And the limitation, of course, is that you can only treat transsphincteric fistulas with this procedure. And in detail, here you see first you open the intersphincteric space, then use this right-angled clamp hooked around the fistula tract. The tract is then divided distal to the point of ligation, and the distal fistula tract is removed, and you suture the defect at the internal of the external sphincter muscle, and the sphincters are readapted. So when we look at the data, the fistulectomy is a very, very good procedure. We have healing rates of about 88%, and one problem of the procedure is the dehiscence is about 8% after the first treatment. But when we look at the secondary repairs, the success rate is about 96%. The drawback in that treatment is that the fistula involving more than 80% of the sphincter results in healing rates of only around 70 to 80%, and incontinence rates, although mostly for liquid, stool, or wind, is around 15%. When you compare the advancement with the mucosa flap and the plaque, we found one randomized controlled study, and the recurrence rate after 12 months was lower in the flap group. And also this retrospective study with 80 patients, we see so the time to failure for the fistula repair is lower in the flap group, and the fistula healing is better in the flap group. And the lift, so very early data, shows recurrence in less than 90%, no recurrence in more than 90%, and also a meta-analysis with 24 articles and many patients showed a success rate after 10 months of 75%. But as I already said, this is for transsphincteric fistulas only. So over the scope clip, We don't do it here. It's a new procedure. Healing rates are described from around 10 to 100%, but it's probably lower. We only have case series, and it's very low in Crohn's disease, only about 30% healing rates. And patients often need revisional procedures, but it does not affect incontinence. So, because I don't have much time left, so we got just quickly through this. Biochemical treatments are very evolving field at the moment, and what we normally do, this is the technique for all these procedures. You channel the fistula tract, you resect the internal and external orifice, or both, and then you do the curettage, you wash it, and then you seal it, and you close either the internal, external, or both orifices. And what you can seal it with is fibrin glue, but you see here the healing rates vary greatly, and it looks that it's more successful in simple fistulas, has a very low complication rate, but we cannot recommend it, so it's only being used in studies. You can add to fibrin the platelets, and then the closure rates are around 50% with one session, and 2/3 of patients are cured after 2 sessions. But also in newer data, the closure rate is 50%. And one very interesting topic is the use of adipose tissue stem cells as sealing material. Why adipose cells? Because they have a similar protein expression phenotype as human bone marrow stromal cells, so the bioactive molecules secreted by stem cells are immunomodulatory and affect a variety of immune cells. Other secreted molecules establish a regenerative microenvironment by establishing a powerful trophic field that should promote healing, for example, in a fistula tract. And of course, the advantage of the adipose cell is the high availability. In Crohn's fistula, so we're talking about Crohn because this is a model for wound healing under some of the worst possible conditions, and many of these treatments were first done in Crohn's patients. And here you see the first series with the stem cells. The healing rate was 6 out of 8 patients, but then in a later series, the healing rate went down to 71% in the mixed population with Crohn's and non-Crohn's fistulas. And even later data shows that there is no difference when you compare it to fibrin glue here. So it's 40% healing rate overall. And one randomized controlled studies done by the group of Panyas, who's a leader in this field. They did a placebo-controlled study, and they reached healing rates of more than 50%. But one of the limitations of this study is the high withdrawal of 40% of patients within 1 year. So I'm going to skip this, and this is the result. So we have a healing rate of about 55% after 1 year. And our study in the USZ is close to termination by the end of 2018, and we treated 20 patients with a curettage and a sealing of a mixture of acetylcysteine antibiotics and fibrin glue, and a surgical closure of the external orifice. But also the recurrence rate is quite high, with 14 out of 20 patients and 1 patient with Crohn's disease. So to sum it up, the mainstay of treatment remains surgery, although there are many newer biochemical treatments. The more sphincter you preserve, the higher is the recurrence rate, and the recurrence definitely is the unresolved problem in the treatment of fistulas. And to conclude, hemorrhoids, we have effective and very safe procedures. Fissures you treat mostly conservative, but chronic fissures you treat with surgery. And in fistulas, we have many different treatments. Surgery is still the mainstay of therapy, but the final chapter has not yet been written. And to come to an end, I show you here King Louis again in 1710. So he had the first successful fistula surgery that has been documented. And he was so delighted about this that the year he was treated 1 year after diagnosis. 1686 was then termed the year of the fistula. Thank you very much.
Yeah, thank you, with this comprehensive review. Clearly, an important problem because, I mean, that's to do with quality of life, with recurrent disease and cost at the end of the day. Maybe one question to our specialist here for hemorrhoid, for example. We see there are different treatment. The danger is for people to use stapler or whatever in the wrong way with disaster. We see, for example, that ligature seems to be okay for every type of hemorrhoids where surgery is required. Should people who do some of this procedure, I'm not speaking about center who do a lot, but some of this procedure, maybe limit the practice to one technique that they do well versus using different technique for treating these hemorrhoids? And maybe you tell us what you do here in Zurich for the different grade of hemorrhoids.
So our shame is really the graphic we've seen. So the grade 1 is clearly conservative treatment. And for the operative treatment, the most common we use the ligature or the longer procedure. And I think the longer procedure has still an important place. If you have circular hemorrhoids, degree 2 or 3, then the ligature is not enough.
I absolutely agree. The circular stage 3 hemorrhoids, that's the ideal indication for the longo operation. And just one tiny little correction is that it's not the stapled hemorrhoidectomy, it's a stapled mucosectomy, because in essence in the longo procedure the hemorrhoids are being left alone and the mucus lining above the hemorrhoids is being resected. And the other comment I would like to make is regarding fistula therapy. You've mentioned briefly in the very end stem cell therapies. That is the most sophisticated way to treat Crohn's disease-related fistulas at this point. There's hopes from the 2 previous studies in the literature. And the company has finally released this product onto the Swiss market and is now nearing certification in Switzerland. And Zurich will be one of 2 hospitals being able to introduce this technique in Switzerland. So we will start treating patients with stem cells by early 2019. The reason why this is limited is because we need to find out what the indications are ideal. The cost for one single therapy is 60,000 Swiss francs. So that's a high price tag, and I'm not quite sure where the indications will go for this procedure. But just so you know, the product is called Alofisel Darvatstorcel or CX601. That's the name of these stem cells. And so hopefully we will see them at OSZ by early 2019.
Why is hemorrhoid artery ligation not appropriate treatment for higher grade hemorrhoids?
Hemorrhoid artery ligation was another hype that came up because it is very minimally invasive. You do not resect large amounts of tissues, and it was a neat technique, so to speak, because you used an ultrasound probe. You clearly detected the feeding artery of the hemorrhoid, and you could ligate the feeding artery, and at the end you would do a suture that would reduce the hemorrhoid into the anal canal. So it looks very, very nice. But then future studies came out to show that the ultrasound guided ligation of the artery did not give any benefit at all. So if you do the same operation by just pexying the hemorrhoid onto the inside of the anal canal, you have the same results when you do a ultrasound guided ligation of the feeding artery. And long-term results just show that it is not, that the recurrence rates are higher than with resectional techniques. So in essence, you have a very elegant procedure with a high recurrence rate, and that's why most people have gone away from it. There's still a number of proctologists doing this. It is minimally invasive, it is sphincter preserving, so there's nothing that speaks against that, but recurrence rates are higher.
Okay, thank you very much.